Thank you for joining me again on a bit of a drizzly Wednesday. And today on our Wednesday slots, I'm going to be talking to other colleagues, so it's a peer-to-peer discussion about matters that might be of interest to our database and people that are listening in today. And today I'm lucky to be joined by a consultant, a gynecologist and obstetrician, Miss Henderson, and she's been a colleague of mine for many years. I've known her for many years, and she shares a passion with me about women's health, women's well-being, maximising and optimising women's health, and she has a specialist interest in the menopause and HRT. And no matter how much access we get to all this information in the national press, the media, it is still an area of a bit of debate, sometimes confusion, and it's sometimes really nice to get firsthand from a specialist exactly their take on all things about the menopause. I'm waiting for her to join, but I'm just going to keep introducing her because there's a lot to say about this subject. And certainly it's a subject close to my heart too, because I'm in that age category where even as a medical doctor, which I am, I'm still sometimes slightly torn on those decisions that should be made, not only for myself, but for patients. Sometimes patients will ask me, and I will be the first to say, I'm not the expert. You need to go and see an expert about this. But nonetheless, I find that I'm asked more and more and more about this matter, and what do people want to really know, what do they want to hear about regarding the menopause. So a lot of these issues are to do with, does it cause breast cancer? Is there an increased risk of breast cancer? That's a real hot potato, and one that's often asked of me, and I'm certainly not the specialist to be able to answer that. I can give the advice that I've heard of from professional colleagues and experts in the field, but nonetheless, that's a big one. And sometimes as well, it's weighing up, again, pros and cons. It's weighing up gain versus negative. And I think that that I will be joined by Miss Henderson, who can hopefully... there she is. Hi, Anne. Nice to see you there today. I was just doing the intro, talking about menopause and dispelling the myths. So I've given you an intro, but can you just give us a brief intro into when you qualified and your experience and what you're most passionate about with all things menopause?
Well, it seems like years ago. I qualified in late 80s, and I then did extensive postgraduate training in menopause, which when I look back, I realized that I was very privileged to have that, because nowadays it's very difficult for juniors to get postgraduate training. They often become a sort of an exam factory, and they have to go from one exam to the next. So I took time out of my postgrad training to do about 4 years looking at menopause, PMS, and I did a lot of work on postnatal depression as well, all under the training of John Studd, who in his day, I mean, he's a well-known name. Many of I'm sure you've heard of him, and many people joining in will have heard of him. And interestingly, he's only just retired, so he's been going for some time.
A long time.
I know. I know.
Right.
So that then, obviously, having done such an in-depth work into those areas, and actually they're all linked, although many people see postnatal depression and PMS and menopause as separate entities. They are linked, not for everyone, but for many women. And I then went on to run specialist clinics whilst I was a trainee, and I've now been a consultant for more than 2 decades, and I've run menopause clinics basically all my professional life. So and I currently see probably well in excess of 1,000, 1,200 women a year, which is
it's a fair few.
No mean feat. Yes,
that's no mean feat. So I'd like to kick off just with something we were talking about before we start answering the questions, and I'm sure people will have a lot of questions, but the thing we talked about earlier on in the week was that you said it was interesting how with HRT, you almost have to address all the negatives and all the anxieties and all the concerns before you talk about the positives, because people come into you almost worried, concerned about all the negatives before they're even prepared to talk about their benefits. And in medicine, that's really unusual, isn't it? Because most of the time people come in and say, I'd like this, or I'm coming to you because I want to get benefit from you. What are the benefits? Why do you think that is, that everybody has the negative spin first?
It's the $64 million question about menopause and HRT, and I mean, we will probably be linking them in this conversation, but obviously many women are menopausal and don't have HRT, so I am going to use them synonymously for the purpose of this chat. The trouble is, HRT's had such a bad press for so many years. I mean, when I look back to when I was a trainee, that was when the first breast cancer data first came out, and it was quite negative at the time. It received a lot of press coverage. It kind of calmed down, and then we had if you like, a honeymoon period for about 10 years, and then we had more breast cancer data, and then even as recently as last year, you know, everybody who's interested will have couldn't have helped but to miss to notice the data that came out in the media in the summer. And it seems that HRT becomes synonymously linked with bad news in many sectors of not just the media, but for the public and in medicine. And as with all medical statistics, you know, if you just look at our current coronavirus issue, there are as many statistics as there are medical experts. You've got to know what you're looking at. And much of the medical data actually gets overlooked, and we tend to focus on the negative side, the breast cancer side, without looking at the longevity, the massive health benefits of HRT, the positive side, long-term positive benefits. It seems to be the negative information that sticks in people's minds, and that colours their concerns, and actually, sadly, I think it more than colours women's concerns. In many cases, it actually stops women from either coming forward to discuss HRT, or even if they start it, they may be too frightened to continue. And that is what I spent a lot of my work doing, getting over that difficulty and making sure women have very accurate information.
Okay, well, let's just take the bull by the horns then, because this was a question, but it is one that we're just going to ask directly. Does HRT increase cancer risk?
The question to that is, it depends. And that's the classical doctor's answer. So if you look at modern HRT, and no doubt we'll come on to what do I consider to be a modern regime, the answer to that question is, in the first 5 years, probably not, and in the long term, the risk is very, very small indeed. If you compare, however, that to older types of HRT, the sort of HRT that was around 20, 30 years ago, which in some cases is still being used today, then there is evidence of an incremental risk in breast cancer in particular. So as with all medicine, the risks depend on what you're taking, the particular types of hormones, whether they're natural, body identical, or whether they're synthetic. And that is what determines the risk. It's not HRT per se, it's the type of HRT that you're on. And that is the key point that women need to understand.
And it's multifactorial is what you're saying. You know, it's risk assessing, it's family history, it's all those things that as a doctor you would take into account. And that, because that is the one thing I think that I was like to say, something as simple as whether a woman has had a hysterectomy or not, that will colour the whole picture, because we've known for decades that women who have had a hysterectomy and who are therefore only on estrogen and don't need combined HRT, there is no evidence, no convincing statistical scientific evidence that they carry an increased risk of breast cancer. And if you think that up to 25% of the population, of the female population, have had a hysterectomy, that's a staggering figure. And you know, for those women who've had a hysterectomy, it's good news. Yeah, I've never heard that data. It's fascinating. And I mean that so if again, I'm going to now come back to that one. So what a lot of people actually say to me is, and again, I see our clinic is not wholly female led, of course not, but as you know, our clinic, I see a lot of women over the years. And what a lot of women find, particularly those, and you'll correct me if I'm wrong about this, sometimes with women with a history of benign breast disease, who've had always throughout their lives quite sensitive breasts, you know, premenstrual, etc. When they go on HRT and sometimes get those symptoms returning, meaning, you know, some breast pain, breast tenderness, sort of tweaking in the breast, they're very worried that something's going on. What would you say to those people then?
Well, there are ways around that, and that breast pain as a symptom is very rarely worrying or sinister. So that's the first message. I've actually had breast cancer colleagues who are specialist surgeons, and when they do their 2-week wait rapid access clinics, if they see somebody who's been referred purely on the grounds of breast discomfort, some of them will actually say to the woman, go home, I don't need to see you, you don't need a mammogram. Breast pain is never sinister. And that, you know, that's from somebody who's dealing with that in their day-to-day life. So I think if a breast surgeon thinks that, then I'm reassured by that. So it's certainly true that some women will get hormonal breast discomfort, and the person who's prescribing the HRT needs to be aware of that, and then the regime needs to be tailored accordingly. So for example, one option would be to start very cautiously, to start with a very low dose of the transdermal gel or the patch, almost excessively low, and then build up gradually over a period of 6 to 8 weeks. I mean, that's one very simple step. And if you do that, then it's very unlikely that the patient will get a significant breast discomfort. It's dose related usually. And, you know, if you manage the strength, then it's usually fine. And another tip is evening primrose oil. It's like a magic elixir for breast pain. High dose evening primrose or starflower oil, and the breast pain settles within usually 72 hours or so. So that's my top tip. Yeah. But you need the high dose stuff. You need sort of between 2,000 and 4,000 units. So taking low dose capsules won't make any difference.
It needs to be a high dose.
Super high.
Apart from the cancer concerns, what do you see in clinic as people's big concerns about? We're going to cover the concerns and then, you know, how it's taken and the benefits, but just, is there anything else apart from the obvious, which is the cancer risk that everyone seems to confuse?
Women then worry about weight. I mean, you know, weight is a common one.
True.
Fluid retention. You know, the top two questions are either, will I get breast cancer? Will I put on weight? And, you know, the answer to both of those is no. Weight gain, again, is an old wives' tale. And all the studies show that women on long-term HRT actually maintain muscle mass, so they don't start to replace fat with muscle with fat, which is that's what happens with middle-age spread. So you're constantly replacing muscle tone with fat, your metabolic rate drops, you carry on eating and exercising as you've always done, but your weight creeps up because your metabolic rate is dropping. And there are a large number of studies showing that if you take HRT, particularly with testosterone, that can be a help, that you maintain muscle mass, so your metabolic rate remains active and you don't then start to gain weight. So that's the long-term benefit, but it is true to say that some women initially will probably retain a small amount of fluid, maybe 2 or 3 pounds at the most. That's fluid. As you carry on with HRT, that comes off.
About how long would they have to put up with that?
6 to 8 weeks, I would say, if that.
So a couple of months.
A couple of months, absolutely. Yes. And one apocryphal tale I've got, which is, I think is probably commoner than you might believe, is I've had a few patients who've become very socially withdrawn because of their menopause. You know, they have anxiety, but within that anxiety, they've stopped socializing and almost become agoraphobic. And one lady came back after 8 weeks and she put on over a stone, and she was livid, and, you know, the HRT was to blame. And she brought her husband with her, thank goodness. And she was saying, you know, this stuff, I put on a stone and weight. And the husband then pointed out that she had barely been out of the house for a year. They hadn't socialized, they hadn't had a dinner party, they hadn't been out to a restaurant. And since she'd been on HRT, they'd hardly been in the house. So she was, probably, eating out, and actually that her eating pattern was the problem, not the hormone replacement.
Yeah, so her lifestyle had changed for the better, but unfortunately.
But it was a positive lifestyle change,
Yeah.
So, yeah.
So what do you feel are the, you talked about anxiety, which is a big one for patients of mine. They often say, I feel, I was a, high powered this and that, and I really feel like I'm falling apart.
Yeah.
But what are the key things that women come to you about that are menopausal linked, or perimenopausal linked, that are just unacceptable ways of living that people do? You mentioned anxiety. Sleep is another one, isn't it? Sleep problems.
Surprisingly, that most people would believe that vasomotor symptoms, flushes and sweats, are the commonest reasons for referral. But in reality, the problems I'm seeing in my clinic repeatedly are the anxiety, the brain fog, so lack of concentration and focus. There's this phrase, loss of nouns, which was coined by an American gynecologist. And it's literally as it says, somebody might be having a conversation and they lose the name for the person standing next to them or the object in front of them. And it's embarrassing, and that makes it far worse. So their fluency of speech is affected, their short-term recalls affected. I've got so many patients who run around with Post-its in their pockets, and if they don't, they'll forget what they're going to do that day. They have to-do lists all over the house, that has quite a humorous ring to it. But, if you're trying to hold down a job, particularly a high-powered job where, your mental function is key, then it can be really disastrous.
Yeah. And somebody's actually said on popping up, and joint pains, and I've definitely noticed that myself, sort of muscle aches, joint pains, that sort of stuff, particularly in the morning.
Yeah, so the classical areas for joint pains in menopausal women are the small joints. So they are hands, fingers, wrists, ankles and feet. Now, obviously, you can get arthritis in those. So some women may have early onset osteoarthritis as well. But if you get a sudden deterioration in symptoms in a relatively short space of time, and you're in your late 40s or early 50s, the chances are there's a huge hormonal component. And studies have looked at the role of estrogen in particular in joints, the impact on collagen, the impact on ligaments, everything that constitutes joints. There's no question estrogen plays a big role. And similarly, replacing with HRT has a big positive impact. The symptoms improve very, very quickly in most women.
Yeah. And I mean, again, from an aesthetic point of view, and I know we're not going to dwell on this today, and it's not that, but certainly anecdotally, a lot of patients come back, and we know that there's such positive health, what we call serious health benefits, the medical benefits. There's also some lovely little add-on aesthetic benefits.
Yeah.
Hair, nails, skin.
Absolutely.
Really, and I can genuinely see that in patients when they come through the clinic, that you can, we talked about this earlier in the week too, Anne, you can actually see people come through, and if they've taken HRT or are taking it, certainly their skin quality is so much better. Apart from all the other, list of health benefits they've got, they've actually got some aesthetic benefits as well. And I'm guessing or assuming that a lot of your patients would say that to you when they come back for their reviews.
Yes, and they often ask, is it my, or is this a definite benefit? And of course, it's the same improvement in collagen that you're going to get in the bones and ligaments. One of the biggest benefits of estrogen is that it boosts collagen throughout the body. And as you know, and you're an expert in collagen and, the things it does, collagen throughout the skin, nails, hair, everywhere. It doesn't happen overnight. You're looking at a good 3 to 6 months, probably longer term really, to get the benefits. But there's no doubt that you see a difference. And the beauty is it's sustained. So I even see it in patients who've had HRT for say 5 years or so, and I may not see them for a few years, and they come back, and I have a large number of patients in their 70s and beyond, and it's always striking when they walk through the door. You think, goodness me, I remember, you know, I always remember them, and invariably they look not just younger, but significantly younger than their age. And, you know, I'm not saying for 1 minute that's a reason to take HRT, but if it's an added benefit, then that's wonderful.
Yeah, it's an added extra, isn't it?
Yeah, absolutely.
Is there an age when people should stop taking HRT? So I had some patients of mine who will remember this lady. There was a lady in my clinic who worked with me for years. I won't say her age, but she was mature, and she was taking HRT really for a very long time. Looked amazing, actually. She looked fantastic. For a very, very long time, and actually had no reason to stop it, was carrying on because she felt so good on it. Is there an age to stop? Do people need a break?
Well, the short answer to that is in most cases no. And I have many patients who carry on to 60, 65, 70. I think my oldest patient's 88. And she has the mental function, and she probably has the skeleton of a 60-year-old. You know, she's
great.
Still doing crossword Sudoku. She still works. You know, she's an amazing role model. I think the myths about when you stop have followed on from the breast cancer issues. So, you know, the longer you take it, there is arguably a greater risk of breast cancer. Therefore, there has to come a cutoff point. But actually, if you look at the scientific evidence in the literature, there is not a single paper that states women must stop at 60 or 65 or 70. These comments have been extrapolated from papers, from scientific data, and they're not really backed up. And I say to my patients, you know, we will have a yearly discussion. I do think ongoing review is very important. So I'm quite comfortable with patients who are taking HRT for 5, 10, 15, 20 years or longer, as long as they're under regular review, their HRT is being monitored, they continue with screening, and any concerns are addressed. And that's, to me, is just common sense.
Yeah,
but I think it's ludicrous. Yeah, you stop at 60, and then the patients will say to me, well, you know, what do I do when I'm a day past my 60th birthday? You know, do I have all my symptoms back? What's going to happen to my bone density and so on?
No.
So, you know, we've obviously got to cover all. Yes. Yeah.
Can you just talk me through, just give it in a nutshell, that you were talking about earlier about the different types of HRT, and certainly the thing that's very groovy at the moment is bioidentical hormones, and sometimes people don't understand what that means. I think sometimes, you know, quite well, you know, well-educated people in healthcare don't really understand what bioidentical hormones means. And is it your favoured approach?
Well, it's the bioidentical argument is quite a tricky one. So the term natural gets used a lot. And natural hormones generally are ones that are derived from soya or yam. Estrogen tends to be derived from soya, progesterone from yam. So you can reassure patients that most modern HRT is natural. But there is a big difference between bioidenticals and body identicals. It doesn't sound, you know, when you say it quickly, it doesn't sound much, but the bioidentical market is largely unregulated, and many of the hormones are not produced by the big drug manufacturers, so they haven't been subject to scrutiny in terms of large cancer trials or, for example, trials on bone density, cardiovascular disease, that sort of thing. Whereas body identical hormones, which are also natural, have been. And it sounds like splitting hairs, but the general consensus view is that the specialists like myself who have gone down the, you know, the accreditation pathway, and, you know, we you know, tick all the boxes in terms of exams and so on, we favor body rather than bioidentical hormones. But they do share, where they share common features is that they are both derived from natural products. The difference with body identical, I can, you know, if somebody says to me, what's the breast cancer risk of this? How much do I need of this to stop me getting endometrial cancer and so on, I can pretty much give them an answer. But it's difficult to do that with bioidenticals just because of the lack of scientific data.
Okay, well that's important, and it is clear because it is confused.
Yes.
It is quite muddled, and people are very muddled on some of these things. And in terms of, I'm going to jump back and then come forward because somebody has asked a question. I think it's important if people are asking just to answer. Somebody asked, can I use HRT with sertraline?
Yes, you can.
Right, okay.
And there's some interesting evidence on SSRI antidepressants, and obviously sertraline is one of them, that they're used for depression and anxiety. There is evidence that these drugs are overused as a first-line treatment for menopausal depression.
Yes,
and they're less effective in perimenopausal and menopausal women than they are in other age groups. I'm not saying they should never be used in that group, but they shouldn't be first-line treatment. The NICE guidance is very clear that HRT should be first-line treatment for menopausal depression. However, I have many patients who are on both, and in some cases, there does seem to be a slightly synergistic or additive benefit to taking both. So I wouldn't say they act against each other. And if somebody comes to see me and they're on sertraline, I would say carry on and let's see how you get on with HRT as well. And it might work even better than one or other alone.
Okay. And does it sometimes, just out of interest, I'm more interested in would it sometimes be the case that if somebody goes on HRT, then that they might be able to wean themselves gradually with their doctors, with your help, or with their doctor? Yeah,
yes. Obviously with the GP support, maybe 6
months.
Yes, absolutely. But yes, and many women are delighted to do that because they may have been on sertraline or citalopram or Prozac or one of the different brands for many years, and of course these drugs have side effects. They're not. They can help mood. Undoubtedly, but they do have side effects. So many women are keen to come off.
Okay. You said earlier that, and I'm quite interested, and you touched on it, but you said that PMS, correct me again if I got the wrong end of the stick, but PMS, etc., was sort of linked to the menopause, the pathways. Can you explain a bit? Because obviously I've gone completely off piste here, but what do you mean by that? What do you mean by that they are linked? Linked in what way?
Well, the research that I did seems to indicate that there's a subgroup of women who are particularly sensitive to hormone fluctuations, and they experience those fluctuations throughout their adult life. So, for example, they may have more profound postnatal depression after their children. There is a lot of evidence that certain subgroups of postnatal depression are not environmental. They're not, if you like, a life adjustment to suddenly, instead of being young, free and single, you're waking all hours and have no sleep. Now, of course, that will have a degree of impact on mood, but there's a fascinating subgroup of women who definitely have much more profound depression, even psychosis. There are links between puerperal psychosis, which is obviously a much more serious condition, whereas postnatal depression affects as many as 1 in 5 women. It's a common condition. But some women definitely have a hormonal sensitivity, and we believe it's because of the huge drop in estrogen levels after the placenta is delivered. I mean, estrogen levels can be 30, 40,000 or higher during pregnancy. And once the placenta is delivered and the mum's breastfeeding, the estrogen levels can actually drop to the postmenopausal range. It's such a dramatic shift. It's almost, difficult to believe. And there seems to be a link in this group of women that when their cycle returns, once they've stopped breastfeeding or they've come off the pill, that they develop quite significant premenstrual symptoms, or PMS, particularly psychological problems. So they don't necessarily get the breast tenderness and the bloating. They might get labile mood, anxiety before a period, and this can get worse and worse as the years go by, particularly as they become perimenopausal. And then as they get into the late 40s, early 50s, the next step is that they get hit with crashing menopausal depression and anxiety. And if you do a retrograde history, it's staring at you in the book. And I now actively ask all my patients about the issue of postnatal depression after they delivered, and it's striking the number of women who had a degree or perhaps even a severe degree. And if you look at their family history, which is even more fascinating, their sisters and their other siblings and their first degree relatives, their mum and so on, may have had that sort of pattern. So there is clearly this almost certainly genetic link. And I think that's really helpful, because you can almost forewarn these women in their 40s that they may need to take proactive steps later on to prevent them crashing. Now, I'm not saying for 1 minute that that's the case for all women,
No.
but I think that subgroup of women is much more significant than we realise, and I think they're hugely under-recognised and often get fobbed off. You know, PMS is such a difficult problem to treat. Women get sent away and told to just get on with it and don't be silly and stop exaggerating, and but it can be life-changing.
Yeah, I know. It can really debilitate people.
Absolutely. So
it's hugely debilitating.
You know, this group of women, I think is fascinating, and that's one of the things that Professor Studd's group focused on when we were doing our research. And you know, he argued that, I mean, we're looking decades ago, but he was arguing that in the 90s, and actually got slightly poo-pooed by the medical establishment. But you know, I truly believe that there's a very strong link in.
Well, that really is, and it makes people, it almost validates the fact these things are real, and they're very real problems.
Yeah, and they're not in your mind.
No, they're not in your mind. There's a question here, if I can read it. Someone just printed these off for me rather than reading them. I'm 3 months into menopause for PMDD. Great mental effect, but caused joint pain. Can I alter the dose?
Yeah, so PMDD, it feeds in exactly to what we were discussing. So that for those people listening in who don't know what that is, it stands for premenstrual dysphoric disorder, which is a bit of a mouthful. And that it's an American term, although we now recognize it in the UK. And that is a condition where women have a particular cluster of premenstrual symptoms that is purely psychological. Really profound, severe depression to, I've seen patients who are almost, if not actually, suicidal. And
did you say suicidal? Because it's breaking up. Yeah. So it's that bad. It's that severe.
Really bad. It's not just a touch of the blues and I can't get out of bed in the morning. It's I can't get out of bed in the morning and I probably want to kill myself, you know. And it destroys lives. It destroys families and relationships. And it's until relatively recently, it's been poorly understood, but there are one or two really fascinating, innovative treatments in the pipeline. One from Scandinavia that is designed to treat the particular transmitter that has been isolated in PMDD, not SSR antidepressants, a very different type of medication. Really? So anybody who's listening, who's suffering, watch this space, because that should be coming online soon. So
and can you just go back? I'm so sorry. How would this manifest itself? It would manifest itself. Say again what PMDD stands for.
So premenstrual dysphoric disorder, and dysphoria is just dire mood, low mood, anger, irritability, anxiety, profoundly labile mood. Swings. Some of these women actually think they might be bipolar or even schizophrenic.
Crikey.
Because they do actually have some good days a month. I mean, they might have 4 or 5 days, sometimes 10 days a month where they.
But that's all.
Normal.
But that's all.
Absolutely. And you can start off with 3 good weeks, 1 bad. But as with a lot of medical conditions, that soon becomes 2 weeks good, 2 weeks bad. And then as you get older, it's 3 weeks bad, 1 week good. And I've seen patients who literally have a window of 24, 48 hours after their periods finish when they literally can function normally, and then they dip again. It's it destroys lives. It's and
it sounds horrendous.
You know, you go to psychiatrists. These women go to psychiatrists and GPs. And firstly, the diagnosis is often missed. They're often told they've just got depression, and that's not the case. And even when the diagnosis is made, treatments are really difficult. Some are effective in certain women, but there's no universal treatment. You know, some women resort to having a surgical menopause. They have the uterus hysterectomy and ovaries removed because they can't cope with the cyclical swings. So when somebody like that hits the menopause, you can imagine it's not going to be plain sailing, because they've still got these hormonal sensitivities, and you have to try and in that situation, I would say, in my view, that sort of patient should only be managed by a specialist. I think to expect a GP to manage somebody with such a complex history is going to be very difficult. Because
I'm guessing some of these are misdiagnosed purely as anxiety or depression, as you said, so have been put on antidepressants and anti-anxiety meds. Wow, yes. Okay, that's really interesting.
The type of HRT you take is critical, because these women tend to be very sensitive and intolerant to progestogen, and as we've discussed already, women who haven't had a hysterectomy do need progestogen, because you need that to stop the womb lining building up. But in the group of women who have PMDD, that can tip them over the edge. So there are some clever tricks and ways around that you can alter the way that progestogens are given. For example, they can be given vaginally rather than orally, and that sometimes helps minimize problems. But you know, it would take me some time to sort out somebody with PMDD, and I certainly would not expect the average GP to be able to do that. It's to do it well is not easy.
Okay.
It's a terrible condition.
It sounds awful. Fascinating. I learned a lot there, a huge amount. Can you just, because we won't make this run any longer than 45 minutes and we're sort of nearing into hours, is there something that, because I've just picked little bits, but from an educational point of view, from an informative point of view, are there things that, you know, you would like to sort of say to people who will be tuning in now, things about HRT, top tips, or things that you feel are very important for people to consider?
If there's one piece of advice that I would give to all women in their 40s and beyond, I would say get informed. I think in any area of health, it helps if you get yourself informed before you seek advice, whether they're coming to see somebody like yourself or myself. It's much easier to deal with somebody who has a background knowledge about the area and has some understanding of the complexity of the problem. And I know lots of doctors say don't doctor Google. I think as long as you're careful that you're looking at good websites, and there are some really good menopause websites available now with quality information, I encourage my patients to read up, get them, you know, find out what is HRT, what can it do for me, what are the different types, what do I want out of it? You know, do I want to protect my bones? Do I want to protect my heart disease? Is there heart disease in the family? Am I worried about joint pains? Am I worried about mood, about sleep, about fatigue, brain fog, all of the problems? And I think if somebody comes to you with that sort of background knowledge, then treating them and managing them is much easier, because you can build on that knowledge. You know, and I think too many women, as I said at the very beginning, are actually quite frightened of the menopause, and they shy away from it, and they might read stuff in the mainstream media, but they don't take it any further, and there is this sort of groundswell of slight ignorance that you know is there. In Dr. Google, there are so many good websites. Women can really get themselves up to date and form their own opinion.
And then they can sit and ask those questions, where, you know, write them down and ask a specialist like yourself. Somebody's actually said, what website recommendations would you give? Are you prepared to give any specific website recommendations?
So if anybody's interested in more scientific data, I would say look at the NICE guidance. That may sound a bit daunting, but it's only 40 pages. It's anybody from the lay public can access the NICE guidance on HRT. It's really thorough. It talks about the types of HRT, the benefits. It's a good starting point, even if you're not a doctor. I would also recommend Menopause Matters, which is probably one of the oldest websites. That was set up by one of my colleagues in Scotland, and it's been going for probably 20 years or so. Very informative. There's another website called Health and Her, which has videos, links to all kinds of different menopause advice. It's got, I've given some advice on it. There's advice from a herbalist, a nutritionist, fitness expert, CBT, sleep expert. You know, it's like a one-stop shop. You've got my website, there's Louise Newsom's website, My Menopause Doctor. And these are all really good websites. You know, there's
really credible. Yeah, really
Yes.
credible websites,
Yes.
which is very important. And somebody did ask this earlier, and I jumped over it, and I meant to go back to it. Just finally, you know, we're talking about hormones. We're talking about seeing a specialist, hopefully to get, you know, doing your research, all the things we sort of know. But nutritionally, looking after ourselves, you know, we all know what we should be doing.
Yeah.
But what are your views on how we can help ourselves in a basic level, meaning, you know, diet, exercise, alcohol? That's an interesting one, because as I've got older, certainly myself, if I drink alcohol in the evening, I will not be able to sleep. Whereas when I was young, I could sleep. So everything changes. What would your sort of well-being, general, easy things that people could do at home in terms of looking after themselves in perimenopause and menopause?
I mean, I think that's a really good point. I recommend that all my patients look at diet and nutrition, either seeing a specialist or you know, just speaking to the GP, getting sensible advice. I'm quite a fan of supplements, not excessively, but I like my patients taking a really good quality general multivitamin and mineral. You know, the Solgar range, you know, these are really good quality ranges. Something like Solgar Omnium, which I don't have any shares in the company, but I promote all the time. High dose vitamin D, 1,000 units is a must. Absolutely essential for mood, bone development. You know, they don't call it the sunshine vitamin for nothing.
No.
And probably slightly more obscurely, I'm a massive fan of probiotics. And the ones that I drum into my patients are brands like Simprove and Optibac. And these are, if you like, the gold standard. They're not cheap, but they have a lot of scientific studies behind them. Simprove in particular is great because it's liquid soluble, so you can just mix it into a drink rather than swallow capsules. And there's so much interest now in the gut microbiome and the impact that has on even things like cardiovascular health, prevention of strokes, heart attacks. You know, it's really fascinating research, and I see that as being very synergistic with HRT. They're great long-term prevention strategies, and I think if women are going to take general care of their health, then diet is important. The one exercise I recommend is strength or resistance training. Women have got to go and lift weights. You know, they all think they're going to turn out to be the Incredible Hulk, but and I work with a company called Goal Masters in London, and they're personal trainers, but at a very high level. And their view is that, and I'll probably be murdered for saying this, but Pilates and yoga are hobbies. Forget it. You need to hit the weights.
I can just see probably ching 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 ching.
No.
All these people who love their yoga and Pilates.
Yeah. Paul Harter, who runs Goal Masters, I'm sure he won't mind me quoting him. He's an ex-lawyer turned fitness expert, so he's you know, he doesn't mess around. And he said to me the other week, he said, if you send me one more of your patients who does nothing but Pilates, I swear I'll kill you.
Oh, that's so funny. So lifting, so strength, weights, we know this.
Yes.
We know that weights are very, very good. It's the way I get out of doing anything that breaks the sweat. It's hilarious. I hate exercise, as I say on many of my, you know, when I talk, I say I hate exercise. I absolutely am not one of these gym bunnies that love to do stuff. I really hate it. I hate sweating. I hate breaking into a sweat. So my only excuse is it's good for me just to do weights. So I'll do weights, but put me on a bike or do anything where I sweat. I'm just simply not interested. So actually you've given me validation now. I feel sort of quite validated.
They're great for your skeleton. The key thing is they also maintain muscle tone. So if you're on HRT and you're lifting weights, your muscles will be in great shape, and that helps keep your metabolic rate up.
Yeah.
You won't put on weight.
Yeah, that is so good. That is
Yes.
such, because you know, people can be, and let's be honest here, as you said earlier, women don't like to put on weight. You know, some people might go, well, does it matter? It actually, for a lot of, it does matter for a lot of people. It fits the way psychologically you feel. So people want to keep themselves looking good. They want to feel that they look good. And I think that I notice even myself, I'm lucky enough to be slim, but skin quality isn't the same as we get older. This is why we're talking about this. You know, the way you can be the same weight you were when you were 30, but somehow, you know, it isn't all distributed in the same way. You know, somehow it's just simply not the same. So actually, you know, look, I caught myself in the mirror today and I was like, oh no, not the same. And it's fat. It is what it is. But ultimately, doing weights does actually keep your posture, because again, I tend to be a bit like this because I'm always leaning over patients, and it does help that, you know, your core and your strength and, you know, getting up off the settee, you know, with a bounce, not sort of struggling up. It really impacts on the way you feel, but the way other people perceive you. If you hold yourself well, you're strong, you're fit,
you look younger, and yeah, absolutely. And you know, I think it's all, again, that all feeds into this sense of well-being. And you know, women who generally feel well have great self-esteem, and
absolutely,
I see this positive feedback loop arising, and the more they feel better, the more they want to do to help themselves, and they then get motivated to eat better, look at nutrition, exercise better. So you get this positive feedback loop, which is
really important.
That's all women want. I mean, I don't think women want to reinvent themselves. I don't get patients coming to my clinic at 50 saying, I want to look 20 or 30. They just want to look and feel a bit better and function and be happy. And you know, that's why HRT is the happy hormone.
Yeah, it sounds fantastic. Anything else you want to say before we sign off? I think this has been, seriously, I've learned so much just from listening to you, Anne. I genuinely have. And my daughter's just in the background here, and she was sort of raised with great interest, and as well in what you were saying, particularly about the PMDD. You know, when you learn about these things, it's really important, because as you say, you can then as a patient go into a specialist armed with some information and have much more from that consultation.
Absolutely.
So anything you want to say as a sign off to anybody, or have you feel you've said a lot today?
I mean, I think we've covered a lot of ground, and I hope I mean, I've enjoyed it. I hope women have found it interesting, and I hope they can build on that, and perhaps go and look at some of the websites I've recommended. And even if they do nothing else, I don't for 1 minute think that you know, everybody needs to be on HRT, but I think there's an enormous benefit to just having an hour-long consultation with someone that you can ask your questions, get them answered, get some general health advice, and then if you decide HRT is for you, that's great. If you decide it's not, you've still made an informed choice. And I think we need to be empowering women to make that decision about whether, you know, how they want to live the second half of their lives after the menopause. Really, they're going to live.
That's a really good point to end on. We live, you know, please God, you know, we live long lives, let's hope, and to actually live, as you say, the whole second part of one's life, living anything other than feeling well, I think we deserve it. I think women deserve that quality of life, and that's the messaging that you were giving today. I can't thank you enough, Anne. I sat here, you know, really, you know, I talk a lot normally, but I've really listened, digested a lot. I think it's been of great value to people, even those people who know quite a lot, and there have been some great appreciative messages here. So thank you, everybody. I'd love to invite you back to talk about specifics over the next few months, because it was fantastic. Thank you so much, Anne. Enjoy the rest of your day, and I hope everybody got a lot out of that as I did.
All the best. Thank you, Tracy.
Bye-bye, Anne. Thank you.
Bye.
Bye-bye.